Hi, everybody. We'll get started. I'm Kristol. I'm a third-year Pediatric Emergency Medicine Fellow at Nationwide Children's Hospital in Columbus, Ohio, and I'll be presenting today with Maegan Reynolds, one of our faculty member combined EM as well as Pediatrics at Ohio State and Nationwide Children's. Maegan's area of expertise, among many things, is quality improvement, which we'll highlight today in our talk on top 5 pediatric advocacy topics. We have nothing to disclose. So our goals for today, we are going to help you educate your pediatric patients and families on ED-relevant advocacy topics that you see listed here. For each of the topics, we'll review kind of 3 main points. The first will be anticipatory guidance that you can use on shift, any shift. The second will be things to look out for in your department or in your community that are easy resources that you can offer families around these advocacy topics. And then the third major point that we'll highlight for all of these topics is how you can take that to the next level, whether it's at the community level or at the state level, to advocate on behalf of kids in the community around these topics. And then for safe sleep in particular, we'll highlight a QI initiative at our institution that kind of combined both QI as well as advocacy, which we thought was a little bit unique and something that we wanted to share. Before we move on to our first topic, I really wanted to put in a plug for really trying to use all of these tips and techniques in pretty much every single emergency encounter in your upcoming shift. There really isn't a bad time to talk about injury prevention and to potentially talk about some of these topics. There will be a little bit of trial and error in terms of figuring out what anticipatory guidance to use when, but even more reason to try it out as much as possible. There are some QR codes circulating for a handout, and there we've listed 5 ways to potentially start the conversation. It was a nice script that we found in a paper, and they offer a 5-step approach. So first, once you've identified this opportunity, ask the families for permission. So you can say, can I tell you a little bit more about how you might keep your child safe in a car seat? Then offer a piece of information or a fact about the topic. So we know that kids need to be in car seats, rear-facing car seats, at least up until age 2, maybe even longer, depending on the car seat specifications. Then instill some hope. So while installing a car seat might be really cumbersome and scary and confusing, once you've got that down and gotten your child accustomed to getting into the car seat with every trip, you'll feel a lot safer running your errands day to day. And then lastly, offer community resources, and we'll talk a little bit about community resources for each of these topics here. So first off, exploratory ingestions. Anticipatory guidance to use in this setting is really emphasizing that kids are very curious. There are a lot of things in our environment that look, smell like things that kids eat and drink on a day-to-day basis, but are toxic. So really important to reinforce to families to keep these items out of sight and out of reach. What you see pictured on this slide on the top is some orange juice and cranberry juice, and on the bottom is tiki torch oil, which bottom, very toxic for kids as an ingestant, on the top, something that kids are used to eating every day. And then things to look out for in your emergency department related to exploratory ingestions. A lot of EDs do have medication lockboxes available to families for free. Usually these are readily available in many communities for free as well, so something very easy to offer families to keep them safe at home. The other thing I'll put in a plug for is if you're not already prescribing naloxone for patients and families that are using Suboxone or methadone. Suboxone gummies can cause respiratory depression and apnea in toddlers and young kids very easily, so really important to equip families with Narcan if you're not already in those settings. taking the next step here. So here's an image from the Consumer Product Safety Commission website, which is somewhere where both you as well as families can report unsafe products or mislabeled products to better advocate for families knowing a little bit more about the products before purchasing them. They both have a website, which we do have a link to in that handout there, as well as a toll-free number. So both families or you could potentially report unsafe products. And one example of products that have benefited from CPSC reporting over the last few years are both high-powered magnets and products containing button batteries, which I'm sure many of you have seen some life-threatening ingestions secondary to these.
So our next topic that we're going to discuss is on car seat safety. So we were trying to pick topics that we know are just prevalent in our emergency department. We see kids all the time coming in after accidents, whether it's minor injuries or pretty significant traumas. And I think before I was a parent myself, actually knowing what the car seat recommendations were a complete black box. So one of the first steps is just having a basic guideline for yourself of what the recommendations are. I think one of the big things to highlight with this is this idea that really advocating for kids being rear-facing for up to 2 years of age at minimum, as well as the idea that many kids actually should be in some type of booster seat until at least 8, if not 12 years old, both by the AAP recommendations as well as based on state-to-state guidelines. So one, knowing kind of what the general recommendations are, as well as knowing just what your specific state advocates for. Additionally, we see a lot of children that are coming in after an MVC. Many times, one of the questions that parents ask is this car seat safe? Should I be continuing to use it? One of the things that we talk about is that you can define an MVC as being minor, where they can continue using the car seat if a couple things are maintained, which is that the vehicle could be driven away after the accident, that the vehicle door closest to the car seat wasn't damaged, no one in the vehicle was injured, the airbags didn't go off, and you can't see any damage to the car seat itself. Another kind of simple rule I use is that if the car is going to go through insurance because there's that much damage, you really need a new car seat. One of the things that can happen that you can actually install within your emergency department is looking at where there are car seat programs. Some emergency departments actually stock car seats so that they can send children home in a safe environment after any type of MVC. If that's not available in your department, then knowing the resources for where to get cost-effective car seats are excellent. Using your social worker, having access to things like WIC that can help to provide families that extra car seat at a more reasonable cost after an accident. When you talk about taking the next step for advocacy, there are the National Safety Week, which is September 14th through 20th, and that's a big national plug to try and get all kids into safe car seats that are appropriate to their age and size and weight. Another great resource to talk about with parents is that many communities, especially many fire departments, actually have car seat check places where you can go into it on certain weekends and have families check and make sure that the car seats are installed safely into the car as well as the appropriate size for the child. So another great thing that can just easily fall into conversation when a kid is coming in after a specific injury. And now Kristol's going to talk about guns.
All right, so we know that the safest place for a child is a home without a gun. But in homes that do have guns or family or friends that have guns, we really want you to emphasize safe storage or safer storage. And principles of safe storage include keeping guns locked, out of sight, and where the gun is unloaded and separate from ammunition. So really emphasizing that hidden does not necessarily mean safe, because as you'll see, a theme throughout our talk is kids are very curious. Kids often know a lot of things that we don't think that they know, and so if you think that the gun is hidden from them, it's likely that they know where it is. The other key piece of anticipatory guidance to potentially include in your encounters is empowering families to feel like they can ask family and friends about if there are guns in their homes and ensuring that they're safely stored. So one way to do that, to empower families to ask about it in a non-threatening way, is to say, you can say, my doctor said I should ask about where guns are stored in areas that my child will play. Timmy is very curious, are there any unlocked guns that are in your home? And that, I think, is a really non-threatening way to start that conversation so that families feel like their kids are playing in places that are safe. Things to look out for in your community. So those medication lock boxes that we mentioned earlier, a lot of them are large enough to store a handgun, so also a useful tool for safe storage in homes. In addition, a lot of community sites have gun locks available to families for free. If you're not sure what those locations are, linked on the handout as well as pictured here. So Project Child Safe at projectchildsafe.org has a search available where you can look to see where there are safety kits in your area that can be provided for free for families. So taking that extra step, reducing gun-related injuries, which we're just glossing the surface here, requires a multi-pronged approach. So there are a lot of different policy levers that we could potentially use to reduce the impact of gun violence in our country. And so this table here, which is a little bit small on the slide there, also linked in the handout, kind of lists and describes each of the policy levers that are active in states, and you can take a look to see what's active in your state, where there potentially are gaps, and how you could potentially make an impact there. So moving on to drowning, pool season is with us. We know that drowning is the leading cause of unintentional death in kids 1 to 4 years old. And interestingly, most drownings, 70%, occur during non-swim times. The American Academy of Pediatrics in 2019 updated their drowning prevention policy statement, and they included their 4 key evidence-based measures to prevent accidental, unintentional drownings in the community. The first tenet is close, constant, capable touch supervision, and so what that means is at least one adult poolside should have their phone put away and should be within arm's reach of any child in the pool. Encourage families to take shifts. They're allowed to enjoy their time at the pool, but at least one person should be playing that touch supervision role. The second key piece that the AAP policy statement mentioned as an evidence-based tool is a 4-sided fence or a completely circumferential fence that's at least 4 feet high to prevent unintentional drownings. And I think the reason for that is we know that many drownings occur during non-swim times, and as we've mentioned before, kids are curious. They are likely to reach into a pool for a pool toy during a non-swim time and accidentally fall in unnoticed. And then the third and fourth key pieces of the revised AAP policy statement include life jackets with boating, as well as competency lessons around swimming as early as age 1. And we know that there are a lot of swim lessons available to kids under 1, and I think the reason that the AAP included that 1-year-old age benchmark is they note that kids don't have the head control to pull their head out of water under age 1, and so that swim competency starts to be developed after age 1. Things to look out for in your community that can really advance drowning prevention are low-cost swim lessons. The City of Columbus has like $2 swim lessons available to families that need them throughout the summer. So really encouraging families to seek those out if they're available in the community. And that leads into taking that extra step. So if you find that those kinds of resources are not available in the community, something that's really easy to advocate for local parks and recreation departments. The other thing that you can help your local community with at that next level is one of the other pieces that's mentioned in the AAP policy statement is something called the Model Aquatic Health Code, which is a CDC document. It has scientific evidence and best practices around pool management and safety management that can be really useful to pool managers that are under-resourced or are at small community pools that might not necessarily know how to keep their pools safe, but really easy document to look at and follow to ensure that they're preventing unnecessary drownings.
And finally, safe sleep. This is a topic near and dear to our heart, particularly at our institution, but also I just think that there's such an opportunity to advocate for this for your families in the emergency department. The AAP, as well as many other safety departments, look to say that really what you should have is the ABCs. So alone, on their back, in a crib. The funny thing is that many times, even in the media, when you're looking at pictures, kids are not put in safe sleep environments. And so parents are oftentimes not aware of what the actual recommendations are. One of the things that we specifically wanted to talk about is we all can have like these 2-minute conversations with our families, and there is a significant impact. But what are ways that you can actually get your department as a team to take on these advocacy roles? And what we wanted to share was actually one that we did in our institution where we use quality improvement principles to really address this idea of safe sleep in the community. So in Ohio, there's a significant infant mortality related to not safe sleep practices. Our institution recognized this, particularly in our county, and decided that we as an institution wanted to address this throughout the hospital, not just in the ED, not just on the floors, but together as a team to really see if there was a way for us to impact how kids were able to survive in infant mortality in our community. So this was a institution-wide program, and I'll share a little bit about what they did elsewhere. But the great part is that in the ED, we had a huge success rate being able to do regular education for any child under 6 months of age about what were the ABCs of safe sleep. Looking specifically, this was our overall hospital-wide goal. So this was really focusing on our county infant mortality and talked about the different types of barriers that were throughout the hospital. One of the things that was so interesting to me was they actually did audits and rounds, and throughout the hospital, less than 50% of kids were actually in a safe sleep environment during their either ED or inpatient admission. If we are not able to model that behavior while a kid is in our hospital, it's really hard to be able to speak to that when the parents go home. So that was actually one of the biggest first interventions that happened, was really getting our staff on board that we as a team needed to advocate for safe sleep even within our hospital walls. So that was highly upfront and initial costs with getting cribs, with getting sleep sacks, all those different types of things, and really empowering the nurses that if they saw baby sleeping on mama in the middle of the night, to pick baby up and put baby in the crib. We then went on to kind of model how that would look in the emergency department. What was the ED able to do in those small encounters? Not just throughout the hospital with kids that are admitted, but how can we impact just kids that are here for a regular visit, for their cough and cold and congestion, whatever it might be. As with all kind of QI projects, knowing what your aim is the biggest key. Our goal was that for any kid under 6 months of age, that 80% of them would have documented safe sleep education prior to being discharged from the ED. One of the best things that we saw was that our team really felt empowered. This was not a physician-driven project. This really actually became a nursing-driven project. They were the ones at the bedside. They were the ones that did a lot of the screening as well as education. And we just saw such a great team effort with this. So we saw lots of different challenges. I think one of the biggest things that we identified up front was that a lot of the education was not in multiple languages. So we actually went through and got both handouts as well as videos that could be put on iPads that could be like taken into the patient rooms that talked about safe sleep in a multitude of different languages. We saw, good times, bad times, all of that. We did a great job a lot of times at screening the patients and knowing where the barriers were. So for example, a lot of times it was this idea that kids weren't necessarily in a bassinet or they were more in the caregiver bed, but we had a big challenge with making sure that they got the education. And even more specifically, what we also identified was not just whether families were having safe sleep practices, but also if there was any social determinants of health or barriers for them actually implementing. And if there were any barriers, we worked with our social worker team to work with those families. At one point, there was a little bit of gossip that was going around town that if you went to Nationwide and said that you didn't have safe sleep, that you get a free pack and play. It was good. It was encouraging our goals, but we can't give out a free pack and play to everybody. But once that narrowed down, we really were able to identify specific patients that really needed those extra resources. One of the big things that we did was just, again, implement and use the tools that were available. So putting this on our EMR, we had a specific icon on the trackboard that flagged if they hadn't completed their screening. When they did their screening, anything that was red was an not recommended practice, so would need to be addressed, as well as a soft stop for not being able to print the aftercare instructions and discharge instructions for kids that were under 6 months that had not completed safe sleep training. Going back a couple slides, the great part was by the end of this quality improvement project, we were over 90%. Our goal had been 80%. We were over 90% of kids were getting safe sleep education in the emergency department, often through those iPads that were in multitude of different languages, as well as through handouts. Or we did have some return visits, so those kids, had gotten it previously and they didn't need it necessarily again. But just trying to say that working together as a team, using a lot of resources, you can get a lot of good advocacy projects. We are running a little bit over, I apologize, but one of the last things I will just say is that there are so many opportunities to advocate for your pediatric patients, both at the bedside on a daily basis. I would encourage you on your next shift to just maybe take one of the tools that we talked about and talk about it with one patient. But there's also a lot of different resources as well. And this website, which is also available from that QR code that we put out, has a lot of those campaigns and toolkits about starting the conversation and the different resources. So thank you so much. I know I rushed a little bit at the end, but thank you so much for your time, and hopefully you can impact another patient. We'll be up here for questions, but thank you again.